Good evening, everyone. My name is Katile Mtuko. The founder and director by a Breakers Youth Initiative. And today we are having our session 12 on building a healthy mother and child training. I think it's 7:10. And I would like to welcome each and everyone. I hope the holiday has been fine and you enjoyed your Easter. So today we'll be having the session on the concept of the family and how we can incorporate the family in maternal health and child health, and how we can help each family member in attaining a good family relationship in maternal health and child care. So today we'll be having our speaker, who is Nick Homolo, who is a student nurse, and he is a member of Kenya Students and Novice Nurses. And our co-moderator will be Leomasi Kitelo, who is our SRH coordinator in BBY High. So welcome so much our speaker, and welcome so much everyone.
Can you hear me? Can you hear me? Yes. Am I audible?
Yes.
Okay. So we'll start this session. Today we are looking at the concept of the family. And I'll be a little bit brief. I think this is cohort 2. We had the first one around last year. And allow me to share my screen. Just a moment. Can you see my screen?
Yes, we can see it.
So when you have a question and when you have something to say, you just ask, and we will have an interactive session, hopefully, at the end of everything. So today we are looking at the concept of family. So I don't know where, because I will wish to see people responding as well. So how I wish to, is there a way I can share it? Okay, anyway, let's just start. So we're looking at the concept of the family today, and basically we're going to narrow it down and look at family-centered care, or FCC. We're looking these ones in connection to maternal and child health, how we can really strive and really work out to reduce the mortality rates that we have seen, and how also we need to work out to enhance the health. We are going beyond zero, meaning there's something we have to do. And I really appreciate the previous sessions that we've had. It has really brought out the idea of maternal and child health so clearly. When you are looking at puerperal psychosis, you are looking at what happened, the antenatal period, postnatal period, the 1,000 years of an infant. I believe most of the speakers have tackled them. And I think we are building on one after the other, So I would like to start with a question, and anybody can answer. it will be very good if you open your mic and then you just speak, because I might not see your text. So maybe with the very basic of you, what is the family? Someone to please help us. What is the family?
Family is made up of mother,
I didn't get you. I don't know if it's my network or your network. Who was that speaking, please?
Okay, I said a family is made up of a father, her mother. My opinion.
Am I stable? Am I stable when I'm talking?
You are breaking.
So I'm not stable, I'm breaking. Can you hear me? Hello?
Yeah. Yes, I can hear you.
Am I really breaking? Am I that bad?
No, yeah, no,
Sorry?
you're not breaking. No. You're not breaking right now. You can. We can't hear you. The speaker's muted.
Hello. I think as the speaker rejoins, we can try to in the chat box the definition of a family. You can just write in the chat box what you think a family according to you is.
Hello?
Hello.
Sorry for that. I think I lost, I had problems with my connection. I'm really sorry for that. I think I have some problems with connectivity, but I'll try. Can you hear me, Katila?
Yes.
Okay, I'll really try. I think I have problems and I'll go very fast now, so that I also don't take much time. So I was at the definition of a family. So throughout, you're going to see how the family has moved in terms of its definition, because families throughout ages have transited from the normal husband or the normal man woman union. So we are also going to see, because the definition has been changed to cater also for others, single parent, people of the same sex, which is ideally might not translate to what we experience in Kenya. But maternal and child health is something that is very global. And one of the SDGs, Sustainable Development Goals, also looks at the total health or utmost health of people, or of mothers, and antenatally, postnatally, and puerperium period. So family-centered care, basically, that is what I'm going to talk about as I link it with maternal and child health and that stewardship all together. It's just an innovative approach to the planning, delivery, and evolution of the healthcare that is grounded in mutually beneficial partnerships among healthcare patients, families, and providers. So family-centered care, you are taking the client as the family, because we are going to also encounter another one called family-focused. Family-focused care, you're looking at a patient in the family. But in family-centered care, you're taking the family as the patient, or as the client, sorry, as the client. So when you want to look at the health of maybe a father within the family, you're looking at how has the health of the father affected even the children or the wife or someone. So that is how family-centered care looks at it. Family-focused, if the father is because all of us belong to families, definitely. Some of us, maybe most of participants here, I don't know, I'm not so sure of the statistics, have families. So you realize that we all belong to a family. So in family focused, you're looking at an individual in that family. So it applies to patients of all ages and may be practiced in any healthcare setting. So most of our healthcare settings, because their government finance has not really adopted these criteria because of shortages in staff, because of what the shortages, that is number one, and then financing of the healthcare system. So you realize that if most of the Western countries or most of the developed countries have really invested in family care, and that's why you'll realize that there is a lot of reduced mortality rates when it comes to most of the diseases or most of the maladies that we have. So basically, that is what we're going to talk about. So maybe we define the family, and after defining the family is when maybe we see how does now the concept of the family play a very key role in the stewardship of beyond zero maternal and child mortality, or it's very essential in maintaining this. Maintaining the health of the mother and the health of the child, because the life cycle, especially for women, it starts with you're born, you get into puberty, you get married, if at all, but you enroll into the antenatal period, you roll into the perinatal period, or the whole thing. Then you enroll into the postnatal period where you're a mother now, and then you go to the period, you go to having a child and the rest. So maybe the definition of a family can also help us in trying to decode such kind of responsibilities, or such kind of need that the family can have, especially in trying to maintain good maternal and child health. And we are also going to see how we, the trainees, or some of us, like Atelier is, I think, is a pharmacist student, are going to inculcate all this knowledge in trying to manage the family as we focus in the maternal and child health. So basically, family is a basic social unit. Family is a basic social unit consisting of parents and their children considered as a group, whether dwelling together or not. So as I said earlier on, a definition of a family has transited, or it has grown, it has evolutionized, it has undergone some stages of remodification so that it also accompanies and it accommodates most of what is happening in the world today. So a basic social unit consisting of parents and their children considered as a group, whether dwelling together or not. Sorry for that. And then the other definition is a social unit consisting of one or more adults together with the children they care for. Then any groups of persons closely related by blood as parents, children, uncle, aunts, and cousin. So I wish to ask a question for the attendance so that I also keep track of how many are together. What are our comments? It's a very broad, you can say anything. What are our comments with any of the three definitions of a family as far as maternal and child health is concerned? What are our comments? You can just unmute and then you speak.
Okay, with regard to the definitions you have given, I think when we incorporate family and maternal and child health, the second definition, is it the second or the first? The first and the second more or less kind of incorporate, because it involves an adult and it also involves children. So yeah, parents and children.
And thank you so much. What's your name, please? Oh, just say your name. who was that?
Teresa.
Oh, Teresa. I think okay, thank you so much, Teresa, for that. I think it's a good one. Anyone else? Like one or two and then
I'm Alice. For me, I think related to maternal health care, I think the second definition of it can be related to it, because we see it consists of, yes, adults and children. And here we find that the adults are
okay.
the ones to take care of the children. So it really caters for that.
Okay, okay. Thank you so much. Oh, you said Alice, right?
Yes, yes, Alice.
Okay, thank you. Okay, thank you so much, Alice. Thank you. So as we look at the family, something that we cannot run away from the family. Family is the basic social unit. That one is constant in all the definitions that you can have. Because from the family is where we have children. From children is where we have members of a community. Because yes, we can have father, sorry, we can have husband, wife, but we do not have children. So you realize that this kind of, am I audible enough?
Yes.
Okay, okay. So what the most common thing that will always stand out is that the family is always the basic social unit. That one never forget about. So consisting of parents and their children considered as a group, whether dwelling together or not. So they can either be biological, they can either be socially adopted, but as long as it's the most basic social unit where because without the family, we can never have a community. So that is how we look at it. Now, when we look at also maternal and child health in a broader perspective, we're also trying to look at external factors. You see, we can have internal factors that can really aggravate mortality. But we're also trying to look at how is the mother, where does she come from? How or what kind of nutrition is she taking? Like if you go to most of the antenatal or most of the maternal and child health clinics, when you come, you have four comprehensive antenatal visits. And in the first one is where we do have a lot of health education. We have a lot of investigations done. We have a lot of supplementations and a lot of or vaccines given for the first time. So we want to try looking at what is her economic power. Because if a mother comes and she's 16 weeks pregnant, we want to look at what is her hemoglobin level. And if you are ascertain that her hemoglobin level is a little bit, maybe like 10.5 or 11 grams per deciliter, so you want to encouraging this mother to take a lot of green leafy vegetables, right? Or you want to start giving her iron and folic acid supplement. So what happens is, have you considered her economic power? Like, is she in a position to acquire what you have said? And you see that one will all be encompassed in the family. So I think we're also trying to look at how a family is quite broad, because if this mother is not in a position to acquire that, then we will be coming back with a baby who has undergone fetal distress because of low blood count, or she has a missed, or maybe she has how do we call this? She has a macerated birth or a stillbirth, things of such a kind, because of things that we didn't really consider the family to be a player in this. And that's why we are talking of family-centered focus. If we are looking at, family-centered care, if we are also focusing on the mother, we have also to focus on the husband, if she has one, or those around her. Then social unit consisting of one or more adults together with the children they care for, and any group of persons closely related by blood as parents, children, uncles, aunties, and cousins. So the other definition, or a very broad definition that we can have as we conclude on that definition, is the family's enduring relationship, whether biological, non-biological, chosen, or circumstantial, connecting a child, youth, a parent, caregiver through culture, tradition, shared experiences, emotional commitment, and mutual support. I'll give maybe a case scenario for a case incident. The moment, maybe when you do a deep midwifery study and midwifery care, you will realize that, especially during the stages of labor, especially when you're handling during the first and the second stage of labor, you realize that one of the key participants is the closest person to that mother. Now, the reason is this, because when you're transiting towards the second stage of labor, what happens is that the emotional condition of the mother changes. And she becomes anxious, she's a little bit of restless. So she needs someone who is so close to her to encourage her throughout the journey. So what happens is, if she is married, then one of the key players that are always considered is the husband. But that one never happens in most of our healthcare centers because of issues with the space and also staff. But that one happens majorly all the countries that are very developed. So you realize that maybe the husband or someone very close to her must accompany her when she is undergoing that stage or when she's transiting to that stage. Because if she has low emotional support, what can happen? Because the second stage, I'm just taking it as a scenario, the second stage always needs the cooperation of the mother. It needs the efforts from the mother as much as there is physiologic changes. Now, if she doesn't do that, or if she's not encouraged to really exercise the muscles by trying also to expel the baby, she can undergo what is called prolonged stage of labor. Now, prolonged stage of labor is any labor that takes prolonged second stage of labor, sorry, any labor that takes more than 30 minutes. And you see that one, if it lasts, the mother will be a candidate for CS. And that one might come with results that we do not want. So we have to look at it in a very broad perspective. Now, one of the functions of the families that we can have is, or one of the aspects that we can talk of in the family is cultural competence. And maybe I just have a little say on this, is that there are some cultures that it's not advisable for men to help women deliver. Yes, they are in Kenya, and they will prefer a woman to a woman, which is something that is good because of issues with privacy and issues with the let me talk of privacy in a broader scope. And this one happens if a woman comes from home and she's so much decided in the mind that I'm going to meet a female nurse, and then where she is, she finds male nurses. Because also labor can be influenced by the emotional input, she can decide to fail on her part. Just what I was talking of some minutes ago. She can decide to fail on her part, and the outcome might not be good. So there's also linguistic, then there's also public health education, just one of the areas of incorporations of the maternal and child, one of the areas of incorporation of the family and maternal and child health. So we have this one called public health education. So public health education, I think majorly it's done by the level 3s, if I'm not wrong, either level 3s or level 4s. Rarely is it done by level 5, but they do still. And I think the Kenyan government has really invested in public health education, but not that much, because currently, I think we still have a significant figure in terms of maternal mortality. I think in Meru level 5, in Meru level 5, the last time we had a mortality was, I think 2 weeks ago, and it was an antenatal mortality because of some issues. So it has done quite good, because you look at the records of those who come for their first clinic. Those who come for their first clinic, they come even before the 16th week, because it should be between the first to the 16th week, I believe. And you realize that when they come, the conditions, maybe their pressures are negative, or maybe they have issues with hemoglobin, or maybe they are HIV positive, maybe they have just some health issues. So realize recognitions of these diseases and these things that can really pose a risk is recognized earlier and acted upon. So public health education as a trainee or as someone who has gone through those studies that we've had before, you really have to adopt these as the first mechanism. And I think that is why we are having this session, because they are to help us have those health messages, they're to help us have those ideas and areas of risk, so that we try also and lower this burden that has really eaten the country for quite some time. Just a minute. Maybe when I'm trying to check if someone has a question or something that is not well understood, you can forward so that I look at it. Just a minute. Okay, so there's no question. There's no question for me, or are we not together?
I think we understand you.
Okay, okay. So I was talking of family focused. Let me also try hurrying up. Family focused. In family focused care, as I said earlier on, the professionals are looking at an individual, and family centered, we are looking at the family as a whole. So in family focused, we might have the desired outcome, but it cannot really give us the or it cannot really assure us that we're going to reduce the mortality burden that we've had in the country. So that is why family-centered care is an integral pillar, especially when we are looking at the maternal and child mortality. And it will also really help us in trying to lower what we do not know. Because if we, maybe an example, maybe Katile, as I use Katile as an example, Katile is a pharmacy student. So if you're always at the hospital setting, you see, there is much more to do with community care. And in community care, you are trying to start looking at the families. And from the families, if you really want to manage, malaria, the way it happens in the Nyanza region, we didn't come, or those people didn't come and maybe covered the whole community or that particular community with the matters. Like what I'm trying to mean is they build they didn't fence an area or a communion area so that they prevent malaria. They started with the families. They started giving those nets to families, and from that one, at least they have achieved a percentage in terms of malaria deaths. So if we are also to look at reducing maternal and child mortality, we are also to look at the whole family, because yes, we are talking about female or women health, but the man is directly involved. the children are directly involved, because if we talk about family health, we're also trying to look at family planning. The man is involved, the children are involved, and also even the extended families, unlike what is now today. So why family-centered care? Because there's a lot of lack of communication, information. And I think that is why we are having this cohort too. The first cohort that we had, I think last year, we really elaborated and we really talked about it. And this cohort too, I think we are also gathering some information to really help us in trying to give out messages that can help us lower the maternal and child mortality. Then there's also exclusion from decision making, because a mother will go to the hospital without the husband, without the mother, without the father, without the children, and they are not part of the decisions. Like they was in the hospital, and I'm sorry to share this because of there's what we call patient's privacy, but maybe to share so that it be a case scenario. A mother just came, and she has had 3 previous like she has gone for CS section 3 times, and then she had no idea of there is what we call bilateral ligation. Bilateral ligation is when you close the fallopian tube, so there is no communication between the ovary and the uterus. So just nurse picked her and asked her, what are you planning with after this CS section? Because after 3 previous, after going for CS section 3 times, you cannot risk doing a normal delivery. So she said, or what she said was that I don't know what to do. And then the nurse decided for her that we can do you a bilateral ligation. And that is how she admitted. And then she was told, can you sign here? So you see, she doesn't have time to consult, and she, as much as she doesn't have time, is that she's not even considerate of the family that she's coming from. So if we are to start from the family, these discussions can be there even before the second scar. It can be there even before the third scar, such that when an informed decision, when a decision is made, is an informed decision that is authentic, that is clear, and that is inclusive. So then there is over-treatment or under-treatment of the family, as we have said. Then there is procedures and policies, and that is some of the things that has really hindered or has really eaten our healthcare system. Before the family is can be considered, we have policies and protocols. We do not have time for those, and so we realize that we do things haphazardly. And then there is also lack of follow-up, either to the mother or either to the person that we are looking at, because most of the times, maybe some of us who are in the healthcare system, and maybe you have gone through the obstetric gynecology section, you'll realize that you have a clinical meetup, just a clinical approach, but communally, it's very rare. It's very rare to have a follow-up to the community and get catch or get hold of this person. And that one has consequences as well, because if we were to do that, we will have really lowered the bad incidences that we have. Like there was an incident that happened just where we are having our clinical placement, where a mother had a 2 previous car. She had a 2 previous car. She was done for the 3rd scar at a local or a level 4 hospital, and then she started developing poor digestion, or what we call paralytic ileus, where the intestines were paralyzed. Now, it was not the first time. It was not the first time that happened. I think the first time that one happened, then she was referred to the level 5 and she was managed. And you see the track or the communication between this level 4 and the level 5 ended when the mother was admitted to the level 5 and they didn't even check further. So we really have a problem in follow-up, because if they had a follow-up, the next one that happened, like this one that did happen, she developed paralytic ileus, and yes, I think, okay, there are polls taken. She developed paralytic ileus, and what happened is after that she developed hypokalemia, and then what happens after that, she developed a condition called Ignivia syndrome, and then the mother on the 3rd day she succumbed, so she died in the high dependence unit. So follow-up is necessary, especially if we take from the family approach, because we'll ask the mother or we'll ask the father, what has been done to this mother ever since? How was she responding to the management throughout her antenatal stage? So those are things that we can really take keen or take care of. So there are those ones that I don't want to go through now. So I just want to present this one, and then maybe we wrap up. The principles of family-centered care. So the principles that we have shared the research sheet. Okay. So principles of family-centered care, and then I connect it, and then maybe we'll wrap up everything. I don't want to keep us for too long as well. So the first principles is the foundation. The foundation of the family-centered care is the partnership between families and professionals, and that is the basic and the most immediate principle. That when we want to help, looking at the family as the client and help these mothers, we really have to form a partnership with them. The partnership is not only with the mother, but it's also with the husband if she's married, or with the close family members, because those are the people who can also help us trying to understand the social setting of that mother. And then maternal and child health, which is part of HRSA, and which administers the Title V program, has developed a series of principles of family-centered care. And family-centered care is quite good. It, for most of the countries that it has worked with, or it's being used, it has really lowered the mortality. If I think you're either using your laptop or your phone or something, if you just Google the maternal and child mortality of those countries that has really adopted this approach, they are very low compared to ours that we are approaching, or we always approach the care in a clinical perspective. So the other one, families and professionals work together in the best interest of child and the family. And that is what we are going to do after receiving this training that we have. That we are going to, the professionals, the families, as much as the professionals, we are co-equals. We are in a normal table, we are equal, and we care for this person, for this mother, for this child as co-equals, so that what we are trying to focus is the utmost for the utmost benefits of both the mother and the child. That is the other principle. I say principle number one that we can ever think of is this one. The foundation of it is partnership between families and professionals, and this one is just it has given it voice, or it has really amplified that point. The other principle that is everyone respect the skills and expertise brought to the relationship. You see, in there's always what we have. I've been one of my rotations, I think not so long ago, I've been to the obs-gyn department. especially in the OBS department, obstetrics. And you see, traditionally, we have had incidences because either we have the midwife, or we have the nurse, or we have the nurse midwife. It's always an environment that it's not always pleasing to many because of the attitude and the responses given by the midwife or the nurse midwife. So if such kind of response can also be guaranteed to the family, you see, they will lose morale, they will lose sight. So there's need for everyone to respect the skills and expertise brought to the relationship. So the family members must know their position and as well as recognize and reinforce the role they play. And this one can be reinstated, or this one can really be assured by the healthcare giver who understands the family. And like right now, you're understanding the family, and you know, because what also is a problem is illiteracy levels, right? And we cannot run away from that fact. So the problem is also literacy, to get them into the know that this is your responsibility as a husband or as a family to this mother, and these are my roles to play, and we are co-partners, we're equal, so that we help in the best outcome. So the other thing is trust is acknowledged, and it's a fundamental thing. Nothing happens without trust. If trust is lost, if you are maybe a quack in the the management, and you give out options that seem not to go well with either the mother or the family, trust will be lost, and they will try someone, the participants or the individuals in this relationship will try to lax their position a bit because trust has been lost. So it's in your capability, it's one of your responsibility, it's one of my responsibility to always maintain a good relationship. And as I maintain a good relationship, I must also give an evidence-based practice, an evidence-based practice kind of approach to this management and this relationship. Then the other thing is communication and information sharing are open and objective. There is nothing that is hidden, and there's nothing that is said that will really seem to inflict feelings or inflict mixed reactions from people. So communication must be open. If there's language barrier, you have to bring in someone who is able to translate or to ease in the communication for you. Because maybe, let me take a good example. And I think I've ever been a victim of the same. There was a time we were at the, we were having our rotation at the obs-gyn section. And then there are two things that the mother is always given. One is called chlorhexidine. Chlorhexidine is the one that is always applied at the umbilicus or at the cord. The one that is remaining after it has been cut. So at the umbilicus apply so that it's a prophylactic dose for infection, because as the child is born, the most open area that infections can get in is through the umbilicus of the navel, the cord that has remained in the umbilicus. And then there is one called tetracycline eye ointment. That one is applied to the eyes, so that as also a prophylactic dose for, there's a condition called ophthalmia neonatorum, the one that affects the eyes. So what happens is you have to tell this mother that this one, because I don't speak the language like my language is different from the one, the area I'm in. So you have to tell this mother But this one you apply in the eyes, and this one you apply around the cord area. And you see, let's take a very lowest example of someone who is really maybe a class 8, or maybe a class 3 dropout, who is a little bit, and the language they have been reared with is the local dialect. So you see, you have to bring in someone, because if this mother makes a mistake, this child gets chlorhexidine in the eye, and then tetracycline ointment in the umbilical, then there is a problem. And this one will be encouraging mortality. So the other thing is participants make decisions together. So both the mother, the family, and also the healthcare professional, you just come on the table and then you agree on what is best for us. Yes, you will have an upper hand in knowing what is good for this family, but you also have to listen to them. You also have to, because we talked of one of the principles is respect and trust. You also have to take charge in respecting their cultural setting, in respecting their communal setting. I want to finish. There's one for, I'm not going to, acknowledges the family as the, there is willingness to negotiate. I think I've talked about that one. So we are not so rigid in our decisions. Any question, please? Any question? Because I think I've talked a lot. Yes, any question, anything, please? Someone speak.
Okay, I have a question. Your topic today was on the concept of family, but I feel like you did leave out the part of teenage and adolescents, because we, like, in terms of sexual health and reproductive health, you've only touched on maternal and child health. Is there the concept of family that is captured in the sexual and reproductive health of teens and adolescents?
Okay, noted. Yeah, I think I was talked something about it as well. Okay, thank you so much. What's your name, please?
Teresa.
Oh, Teresa. Okay. Thank you, Teresa, for reminding me that. Okay, thank you for being here. Someone else? Okay, maybe as we go along, I think I'll not keep you for long. Maybe as I conclude and respond to that Teresa has brought out, sexual and reproductive health is broad, and there is much to talk about when we talk of sexual and reproductive health, because one of the things I think sexual reproductive health, and I think if my mind serves me right, we are looking at the maternal and child mortality as we, and have it in okay, immaculate very LGBTQ family setups. What's your question? Like, what does that? Maybe you can explain or you can unmute. Yes, so that I get the question. Very good. So sexual and reproductive health is good, as I said before. And I think I focused so much on family-centered care because I really wanted to talk of of maternal health mortality, as also we look at the sexual and reproductive health bit of it. And the reason as to why I read that is because we have fought, or we are in the fight, but there's some aspect of laxity. And I also draw lessons from what I see, because currently where we are, there's a certain level 4 hospital here, and they always have a lot of deliveries, and to some extent we have mortalities. And the Kenyan government has really invested a lot. It has invested a lot in maternal and child health mortality. But coming back to sexual and reproductive health, as we also look at the family, because we said family is made up of father, mother, and children. And there's that stage of development. There's this sociologist called Eric Erikson. He comes up with, I think, a 13-point stage of development. And there's changes in life. When we have the family, one of their responsibility is to cater for the health and also for the changes. Now, when you're looking at the sexual reproductive health, especially in terms of adolescents and in terms of young adults, we also have issues that comes in. Maybe there's that stage of maybe an example is a girl transiting from getting into the pubertal stage. They have issues with menses, they have emotional changes, and the family is still the center, because as a healthcare profession or as a healthcare professional, yes, you want to handle this lady, you want to help her to adapt the changes, and you are telling her, or you are advising a lady who comes from a family that never speak about these issues. They feel it's more of social sacrilege to mention them within their conversation, or you want to talk to her to be open, and you want to talk to her to exercise freedom, especially in explaining issues health related to pubertal changes, and the person who is close to her never wants to hear this. So you see, so we approach that family, and we approach the lady, and the lady forms part of our client. So that is why I am really so much on family-centered here. Because as much as we will be sorting out, someone has maybe a sexual and reproductive health disorder and a sexual reproductive health disease that we can talk about, maybe syphilis, maybe gonorrhea. See, we are also managing gonorrhea, but we're not only managing gonorrhea to this lady alone. We are managing this gonorrhea as we also try to bring the reality to the closest family. Because if support is from the family, I tell you for sure that this person will recover very fast. If there is support in the family, even issues, menses, or issues with pubertal changes will not really be a big deal to these ladies. Issues, pubertal changes, even to men, or these complications that can come forth, they will really not be an issue, because we are handling a client who understands the changes. So I think maybe I've tackled on that one, but I really focused on maternal and child mortality, so that as we go along, we also broaden our way of thinking. So maybe I mentioned the benefits, and then I also invite questions. So benefits of family-centered care to the family: number one, it improves patient and family outcomes, because we shall have catered, or we shall have managed this mother from the center of where she is, where she spends most of her time. Then increase patient and family satisfaction. I think that one. we have really talked about it. Then to the staff, it increases professional satisfaction, because one of the things that we can never go without saying is that you always feel a little bit encouraged when you see someone who was in a health was at risk of a certain health condition, or developing a certain abnormal health condition, when they have recovered, and this recovery has been brought forward through the approach of the family. So it goes without saying that we also feel that sense of satisfaction. So that is what, and that is what makes us, or that is what keeps us going. So when FCC is a cornerstone of our agency, guiding principles, staff show more positive feelings about their jobs, and it creates provided sense of teamwork. And then it also generates new, previously known information from the family. And then in terms of costs, it leads to more effective use of healthcare resources. So maybe I'll invite someone to explain to us this one as we also summarize. Maybe I'll invite someone, because I think this one we can explain it in a diverse manner. Someone, please.
What's your question again?
My question is, what of we have seen the statement written there is lead to more effective use of healthcare, because one of the benefits that it will decrease the cost. So we can cut these costs in diverse manner. So that is my question is, what are your thoughts in terms of cost as a benefit of family-centered care? Did you get my question right?
Yes. And when, okay, I think when it comes to cost, decreasing the healthcare costs and all that, I will think of it in terms of like the NHIF cover. That's where my mind goes to when we talk of in terms of costs and reducing the cost of health. I think that's where my mind goes to. Yeah.
Okay. So what about NHIF cover? Kindly speak more on that.
Sorry?
Like what about NHIF cover? Like you have spoken of something about NHIF. Tell us more. I really want to listen to that point.
Okay, we have the NHIF, and also when it comes to maternal and child health, we have the concept of Linda Mama, the cover. So,
Okay.
when you have the card, if your kids are below 18 years, it would cover them, like they are at liberty of using or benefiting from card ya mzazi. So I think within and the concept of and NHIF, the health to the family in a reduced and services more used with the family members, because it's not that costly. Yeah, that's my two.
Thank you so much. Thank you so much for that insight. Thank you. Are you a nurse?
Yes.
Good. How many years of practicing?
I just graduated last year in 2021.
Oh, last year. Okay.
Yes. Yeah.
Okay. Thank you so much. Thank you. That is a very good insight.
I would like,
Yes, please.
yes, I would like to, I don't know, to comment on what she said. She's Terry. Okay, she said about the
Yes.
NHIF cutting costs. But then
Okay.
again, remember, in some
Mhm.
facilities, I don't know if it depends on facilities or it's just overall the NHIF. There are some services, there are some drugs, there are some tests which they say that the NHIF cannot cater for. So maybe to some point. So you find that yes, there are some services, some drugs, what and what have you. Still, the family will still have to cater for whatever is needed for the teenager. For the, like to say, let's say for an example, some tests to like my
Mhm.
facility where I work. There are some tests. Let's say example the HB. It is being catered for
Mm.
NHIF doesn't cater for it in cash, you see. So it's somehow contradicting.
Mm. Okay. So I don't know if she wants to respond or I can maybe give an input.
You can give your input.
Okay. Okay. So what I think is that what she said, maybe she mentioned NHIF and then she also mentioned Linda Mama cover. And maybe how I understood her point, if I'm not wrong, is that in when looking at family-centered care, we are considering the family as the client, right? And it will be very less costly to the family because yes, Linda Mama has seen that there is need to reduce maternal and child health mortality, and they have decided to cater maybe for the client using the family focus. So the family as a client has a reduced support, financial support to this one of their own. I don't know if that is what you meant. I think it was relevant. Was that the thing you meant?
With the issue, okay, my point was just when in terms of, because when it comes to health, we advise, when it comes to health and
Okay.
we advise people to take this cover as an NHIF. It was just my opinion, my contribution. Maybe someone has
Okay.
how this reduces the cost of health to the family. That was one of
Okay.
my of how to reduce costs. Maybe kuna mwingine akona another way. I don't know
Oh,
that.
okay.
Mm.
Okay. But I think maybe right way because we're looking at the family as the center. And when we have Linda Mama and we have NHIF, what it will do is people won't be having a burden in trying also to cater for the same person. Someone to mute, I don't know who is that. Yes, to cater for the same person to get the help. Yes. So the family is saved that burden. I think if I got you right, or if I got because we're not looking at even that individual because family centered care is the whole family as much as one person is involved.
As much as one person is involved.
Who might be that?
Who might be that?
Yes. Good. We are now good to go. So we are looking at the family as a whole. So the other way it also saves cost is because maybe within the same family, there is someone maybe suffering from a disease. You see, instead of waiting for this person to come and you have an initial. Okay, sorry for that. So the other thing is that you can get, instead of waiting for an initial clinical meetup, you can handle this mother, or you can be handling this adolescent maybe with some health complications. And then what happens, you also encounter someone with another disease, right? So as a healthcare professional, yours will not only be to the mother, it will not only be to this child or this lady with problems with menses, but you'll also start looking at how to help this other one who is sick. I don't know if you're getting me. And if you start handling that person from the family setup, you realize that the family will not have struggles in spending for the health of this other. So those are the ways in which family-centered care also saves, or it's less costly when it comes to sustaining the health of the family as a whole. Maybe the last point is that we have talked about healthcare professionals, greater understanding of the families and strengths, greater family and child satisfaction that we talked of, and then most of the challenges you can ever find, the financing bit, because our healthcare financing as Kenyans has really gone down. Then families are often at odds about appropriate proceedings, maybe the time to meet, maybe what to agree on. So that one is also a challenge. Then maybe at odds with the concept of evidence-based practice, because there is culturally accepted way of doing things, and there is scientific way of doing things. So at times we might not agree on a standard table on what to do. Then definitions of families are continually difficult. I think someone asked about LGBTQ. And I wouldn't, maybe someone will respond to this question. I wouldn't want to talk about it, but as Kenyans, or as maybe speaking from the constitutional bit of it, everybody has a right. But as Kenyans, and in our Kenyan syllabus, we haven't really adopted LGBTQ kind of family approach. I don't know, maybe if my memory serves me right, I am not so sure. But if we have, I don't think I have something to say about it, because it's quite complex, and I have to be very careful and very keen with my words. So maybe if someone has something to say, maybe I'll open as I finish. Then sometimes it's at odds with regulations or even laws. And then the other thing, it's very complex. At times it can be very complex, and it needs a lot of diligence and patience. So that is basically what I would give in as an input to the concept of the family when you're looking at sexual reproductive health and maternal and child health. Maybe if someone has a question, an idea, an input, a subtraction, they're all welcome. So please, anyone? Someone please, or you can even write in the chat box. You do not have to ask a question, or you do not have to speak, even saying hi. You're allowed. No one wants to speak. Maybe let me call names. Alice Meshak. Anne Owino, kindly say something. Yes, Teresa Musila.
Okay, so on the summary, it's saying family-centered care is a mandated approach for public health MCH services. So does this mean that is it how am I going to put this question? Like, do you do family visits in the community? Ama ni when the family members like ni wao sasa wajilete hospitali to get these services?
Okay. Maybe to clarify on that, you see family, they might be a number, right? They might be quite a number, maybe like 6, 10. And we're also talking of the cost. You see, cost might be, that means of coming to the healthcare center. And you see, when we come to the healthcare center, we are talking of clinical approach. So it's more of communal approach. So it's us to go and meet with the family, because the first instance that we meet these people is in clinical area, and then we make contact, and then we follow them afterwards.
Okay.
Someone else, thank you, Teresa, for being active and for responding. Someone else, if there is no one else, I think I'll take it back to Mercy. Mercy, if you can hear me, being that there are no questions and there are no other responses.
Thank you so much, Omolo, for the session. It has been interactive. Okay, though many people are not responding or saying if they are following or not following, but it has been the best session. Learning more on family and how family is incorporated into reproductive health. Okay, I think everything, really, reproductive health is a factor. Like, we have to have reproductive health so that we may have family. Thank you for those who attended. Thank you so much. You can have Cantilla saying something before we end. And if there is someone who will later on have any question, you can just send it to me, then I will forward it to the speaker, then we'll get back the feedback on the classrooms. Thank you so much. Okay, there's someone saying, thanks, the session was awesome. The network was poor though. Oh, a moment. Thanks for the session. The session was awesome. The network though was slow. Okay, Katile will talk later. She's a bit held up somewhere. And then there was a poll. I hope everyone answered the poll, the question that was on the poll. Yeah, we get the feedback on the poll. But thank you. Okay, Michelle, do you have anything to say? Maybe a question or something else. Okay. I will share the I will share the notes on the classrooms. Then we'll go through them. Just have any question, just inbox me, and then I will let the speaker know. I will post the answers on the classroom for everyone to see. There's someone saying that thanks, the session was good. Thanks a lot to the speaker. To my fellows, let's keep the attendance even better. That's from Nahashon. Okay, thank you all. Will you post the notes in the Google Classroom? Yes, I will post the notes on the Google Classroom plus all the previous notes. Okay, we have been on a short holiday. The Easter holiday has taken our time, but we are now back. We'll post them in the classroom. In case you have any questions, just inbox us on the classroom. Thank you so much. Thank you, Omolo, for your session, for your time. Though it was an ambush, didn't tell you earlier, but it has been a great session. Thank you so much. If there's someone else who wants me to say something, let me unmute everyone. Then you can say you can unmute yourself and then say something before we close it. Okay, we have already posted even this already in the classroom, so you can go and get the notes on the classroom, go through it slowly by slowly, understand more. Yeah, I think we can leave at that.
Yeah, thank you so much, Mercy. Though it was an impromptu, but thank you so much. Hopefully we'll still have another session maybe, and we'll interact more. Thank you so much.
Okay, you're so welcome. Okay, to the rest of the participants, see you on Thursday, same time, and we'll having another interesting topic. Thank you. Everyone has a blessed